Vignesh.
Vignesh, start.
अभी नहीं रुको रुको रुको
This meeting is being live streamed. आ गया धीरज आ गया.
Yes, sir.
yes 6:30
Harshdeep, start.
Yes. A very good evening to all present. Welcome to the ISC online PG class. I am Dr. Arshdeep, Senior Resident at Gyan Sagar Medical College, Patiala. I will be your coordinator for today's class. Let me also introduce my co-coordinator, Dr. Vignesh. He is a Senior Resident at IGGMC Hospital, Nagpur. Today we have a very important class and very eminent faculty with us. The topic is interpreting and analyzing X-rays. Radiological investigations are sometimes very important for planning the entire anesthetic management. However, the expertise to analyze the various radiological reports is itself a skill. These are important components of PG exams as well. Before we start today's class, it is a custom to invoke the blessings of Ma Saraswati. I would now request our Honorary Secretary, Dr. Bajwa, to say a few words. Sir, please.
thank you Ashdeep. Today's class I think for everyone in the audience will love to hear, because the person who will be moderating, the main person, is Dr. RPS Gedu. Who doesn't know him in India? And he's a teacher of teachers, and we will love to hear from him, from his students, and along with Dr. Ramesh Reddy sir. because X-rays, whenever we are facing in the during our PG career, also when we are faced with analyzing or interpreting, very difficult sometime. I think you require a special knowledge skills. You may get I think, some interpretation by looking at a first, or sometimes there are many things which we usually miss because the anesthesiology sciences, this science is not directly related to the radiological science. We are only dependent upon the radiologist, but it has evolved over the time. Many new things have come up, and new techniques, new methods have come up. I think those will be touched upon today by Dr. Gedu sir also. How to analyze, how to interpret, and how it can be successful in planning the anesthesia management for patient, especially in the during the pre-operative examination of patient undergoing any surgery. So, without wasting time, we should start the class. I think, Dr. Ashley, you should be starting the proceeding from here.
So Dr. Vignesh will take from here.
Vignesh, please.
Good evening, everyone. Respected dignitaries, senior faculty members, and colleagues. I am Dr. Vignesh, Senior Resident, Department of Anesthesia, IGGMC Nagpur. It is my great honor and privilege to introduce our esteemed moderators for the day. We have with us an illustrious figure in the field of anesthesia and pain medicine, Dr. R.P. Gedu sir. With an impressive teaching career spanning over 39 years, sir has been a cornerstone for academic excellence and clinical expertise. Sir is presently a professor in anesthesia and the head of the Department of Pain Medicine at D.Y. Patil Medical College, Navi Mumbai. Sir's contributions to the postgraduate education are unparalleled, having served as an examiner for various prestigious degrees such as MD, DA, PhD, DNB, and PDCC in pain medicine for a remarkable 134 times. His scholarly impact extends to the global stage with over 510 presentations at national and international conferences. Sir has held significant leadership roles, including serving as the past secretary and president for the Indian Society for Study of Pain, shaping the future of pain medicine in India. Sir's editorial prowess is evident through his contribution to various books and chapters in pain medicine. And Sir is also a member of the editorial board of the Indian Journal of Anesthesia, Indian Journal of Pain, and the Bangladesh Journal of Pain. Sir is an internationally accredited faculty with over 35 peer-reviewed publications, 34 book chapters to credit, and Sir has been awarded the Lifetime Contribution Award from the ISSP and PRAC in 2020 for his contributions to the field. Sir's specialty interests are diverse and impactful, ranging from difficult airways and postgraduate teaching to cancer pain and palliative care. Next, we have with us another highly esteemed faculty in the field of anesthesia, Dr. Ramakrishna Reddy sir. With a robust academic and administrative career spanning over 21 years, sir is presently the professor of anesthesia and the medical superintendent at PMR Medical College, Hyderabad. Sir's specialty interests encompass ENT trauma and obstetric anesthesia, areas where he has demonstrated exceptional expertise and dedication. In addition to serving as an examiner for MD and DNB programs, Sir is a sort of faculty invited to speak at various state, zonal, national, and SARC conferences. Sir's leadership is further evidenced by his roles as a governing member of the ISA National and as the past secretary of ISA Telangana State. Sir's outstanding contributions to the field have been recognized with the Proficiency Award by the ISA National in 2022. Sir has over 15 publications in both international and peer-reviewed journals. We are truly fortunate and grateful to have our moderators with us today. Our presenters for the day are Dr. Chinmaykar and Dr. Dheeraj Dutt, postgraduate junior residents, Department of Anesthesia and Critical Care at D.Y. Patil Medical College, Navi Mumbai. Before we proceed, I request everyone in the audience to mute their microphones and turn off their videos for the duration of the seminar. Any queries you have may be posted in the chat box to be discussed at the end of the session. Wish you all a delightful evening filled with inspiring thoughts and insights and enriching discussions. I request the respected moderators to take over for the rest of the session. Thank you, sir.
Sir, unmute yourself. Sir, your mic is muted. Yeah.
Now, yes. Thank you so much for the organizer. Actually, there was a difficulty in unmuting, but now it has been unmuted. So I would love to invite, of course, first thanks to Sukhminder and ISC team entire for making me a part of it. And now I will love to invite my two students, that is Chinmay Kar and Dheeraj Dutt. They are going to present some couple of slides which they will read, and thereafter I will start telling you how to read any X-ray. And I got a different variety. I mean, it will be really shocking to all of you to see those things, which can be kept in the exam anytime. So I got those X-rays also. I love to show that, and I love to teach that also. So I think let's start with either Chinmay or Dheeraj. Who wants to start?
I'll go ahead, sir.
Yeah, you start. Then
Yes.
Dheeraj,
Yes, sir.
you'll have to present your slides.
Yes, sir. The thing is coming, sir.
Yeah.
Yes. This here first it's a chest X-ray taken in PA view. I always prefer a pattern in which we should always look at a chest X-ray. It is A B C D E F. A for airway, B for bones, C for cardiac shadows, D for diaphragm, E for effusions, and F for foreign bodies. Over here, the airway looks normal. It looks central. We can see about 8 to 9 ribs. The cardiac shadows look okay. The thoracic cavity, less than half of it is covered by the cardiac shadow, so there is no megaly. The diaphragm looks okay. I think we can also see an air bubble in the stomach, which means that the patient is in an erect position. And we don't see any foreign bodies or drains or lines or anything as such. So I would prefer saying this as a normal chest X-ray if proven otherwise. Yeah, this looks like a normal chest X-ray.
Go to the next. Go to the next. Yeah.
Over here, if you see, we see medial lobe and lower lobe consolidation. The airway is not deviated, so that is okay. And we see consolidation in the right side more than left side, and left side is more ventilated than the right side. And the hemidiaphragm shadow is also very clear. Cardiac shadows are not very clear. Air bronchiograms are also seen on the right side. So I think this could be pneumonia, a medial lobe and lower lobe pneumonia.
Yeah. Go to the next slide.
Oh, this looks like a left-sided lower lobe pleural effusion. We're talking about airway. There is a right-sided tracheal deviation. There is opacities in the CP angle. So no bronchiograms are also not seen. We can see fluid accumulation, and we can see a meniscus sign where the concavity of the upper border and the ascending tip of the lateral border we can see as it is marked. That is a good sign of pleural effusion. And yeah, I think this is left lower lobe pleural effusion.
If I can ask you one question over here,
Yes, sir. Yes, sir.
I will say that this may not be pleural effusion. I will say this is a hydropneumothorax. How you
Yes, sir.
differentiate between that?
There is also a silhouette sign that can be seen because the interface between fluid and hard borders are not very distinctive. But
Asking about that, I'm asking about
yes,
how you
sir.
differentiate between hydropneumothorax and pleural effusion, because there is no ICD put as of now. Patient has just come.
Yes, sir.
Anyway, doesn't matter. I'll answer later.
Yes, sir.
Let Chinmay come. Chinmay. Where is Chinmay? Chinmay, please.
Hello, good evening, sir.
Yes.
So actually, I had some problem with unmuting myself.
Okay,
Yes.
start.
Yes, sir. I would request Vignesh sir to kindly share my slides, sir. Share it in the group.
It's already started.
Yes. Sir, good evening, everyone. Myself, Dr. Chinmay Dashikar, and first of all, I would like to thank Gedu sir and all the rest of the faculties, Dr. Sukhminder sir, to allow myself to read these X-rays in this platform. So in this X-ray, what we can see generally, what I have been taught is that we approach the X-rays by first looking at the patient details. If we are not getting the patient details, second thing which I would see is assessing the image quality. In this diagram, I can see that it is a PA view, well exposed with no significant rotation. There is adequate inspiratory effort in this diagram because I can see probably around 10 posterior ribs above the diaphragm. Coming to the systemic review, I can see the trachea, it is centrally placed. There is no any obvious sign of any deviation or narrowing. The bones and soft tissues are normal. There is no, I cannot see any clavicle fracture or any bone fracture or any lesions. The cardiac silhouette is also normal. The heart size is normal. No cardiomegaly, and the costophrenic and the cardiophrenic angle is also there. Bilateral lung fields are clear. This is and I don't see any signs of any mass or increased BVM or any pleural effusion. No consolidation, no mass. This is a normal chest X-ray PA.
Go to the next slide.
Again, in this X-ray, sir, apart from the normal points how we approach, I can see that there is some homogeneous opacity in the right lower zone. And there's also I can see there's evidence of sternotomy done in this patient because I can see there are sutures taken. So this patient is probably a post-operated case of possibly any lung surgery or maybe heart surgery, CABG. There is obliteration of the costophrenic angle. So that would suggest that it could be possibly pleural effusion or any mass, a homogeneous mass, a mass which shows a homogeneous opacity in the lung field. Could be a nodule. So
next,
I can also see there is fundic gas in the left eye. So this is the third X-ray. In this X-ray also, apart from the normal points, how we approach, I can see there is increased BVM, and there's also heterogeneous, non-homogeneous opacity in the left hilar region, and there's also prominent bronchovascular markings alongside, and this could possibly some mass, maybe some mediastinal mass, but it would require further evaluation and further detailed history of the patient, signs and symptoms, and definitely more imaging studies like HRCT to know what kind of mass is this and possibly for the diagnosis.
Okay. Thank you, Chinmay. Thank you, Dheeraj.
Thank you, sir.
I think Sukhminder, things are okay. Vignesh, was it okay to begin with?
Yes, sir. We can proceed.
I think now it's time for me to start.
Yes, sir.
Yes, sir.
So shall I start now?
Yes, sir.
Yeah. So what I'm going to start is, because this is one of the very important things that is being asked in the examination. So for all PG students, this is a very important chapter because there are multiple type of different X-rays that are being asked, and sometimes all the students, they just uh, sort of reach the diagnosis state that this is an X-ray showing pleural effusion. Ideally, when you are a student, you are not supposed to talk like that. You are supposed to read the X-ray in a proper language. Same thing happens with the ECG and all those things. So how to read the X-ray properly, I'll come to that. Oh, what happened? Next slide. What's happening? Next slide is nahi aa rahi.
We can use the cursor at the bottom of the screen.
Yeah. So whenever I'm using that only, whenever an X-ray test is being shown during the examination, please, one must read it in the following ways: whether the projection of the X-ray is correct or not, whether the orientation is correctly placed or not, whether it is normal way or a rotated one. Because whenever it is rotated, you will find the heart is looking little bigger or smaller, and the other part of the lung which is being rotated will look very different, and plus scapula and all those things will also look different. Then whether the radiation exposure of the X-ray is correct or not, very poor, whether the patient is breathing properly. I mean, is it a inspiratory X-ray or expiratory X-ray? That also carries a lot of meaning because every diagnosis changes. And are there any foreign bodies in the X-ray also or not? Foreign bodies can be anything, right from your IS tube to the endotracheal tube to the valves to any other foreign body, coins, ICD, everything can be a possibility, or even pacemaker. So that also has to be told last. But before that, you must read the X-ray properly. So if you see how to read the X-ray, first thing, always there is a label of the X-ray which shows the date and patient case number. You need not see the patient case number, neither date also, but you can see it is very old X-ray. Then side markers on the film is also important. Do not miss whether it is a dextrocardia or situs inversus. What exactly the difference, I'll come to that when we come to the dextrocardia slide. Then there is a technical quality of the film, whether it is projection, rotation, what I already told you. Then look for any abnormalities, and then which category it belongs to. Is it too white? Is it too dark? Is it too large? Or is it wrongly placed? This also has to be seen. And then see where is the lesion, whether it is mediastinum, whether it is in lung, pleura, heart, chest wall, all those things. So left side of the film is the right side of whatever you see on the X-ray case. Left side of the film is the right side for the individual patient. The denser the tissue, the whiter it appears. Thus, the dense tissue are radiopaque and bright in the film, while less dense tissues are radiolucent and they appear to be dark in the film. So if you see the air, if there is air in the X-ray, it looks very black. Fat looks gray. Soft tissue and water will look lighter shade. while bone and metal will look absolutely white. So that is also important. So if you see this glass picture, where if you see the above, here it's air which looks very dark, fat looks little darker, I mean lesser dark, then water a little more lesser than, then white is bone and all those things. So that is very important thing for us to know. So if you see, that's the difference how the color changes from black to down. So if you see the black color is for air which is present in lungs, trachea or outside the body, because it can be just outside means there may be pneumothorax, there may be pneumoperitoneum, there may be something else also. Then there is a fat which looks as a perineal fat or facial plane. Then water will be there. It is lesser black, further lesser black, and white will be the metal which is filling. So if you see this X-ray, how it looks, if you see the label, here it is correctly labeled, then the date is also, its right side is here. So that is also mentioned very clear. Then whether it's chest PA view also, that is also mentioned. Remember, when you see the PA view, you see the X-ray, lungs, and all those things properly. But when you see the AP view, you will see the vertebra and the ribs more better. So that's the difference between that. And plus, date and time is also been mentioned. Now, this is a projection technical problem, that is orientation. I'll come to that individually also, how it is to be decided. See, if you see, this is the X-ray, how they have been taken. So this is the PA view, how it has been taken. So patient is facing directly towards the film and the click is from the air. While the AP view is from top, the film comes, patient is lying down. So the, what you call, X-ray has been kept down. So this is how it will look. The PAV will look, and see the APV will look, how it will look. Here, the lungs are looking much more better, heart is looking much more better. While here you can see the ribs and even the lungs are looking little milder. And if you see, the scapula is also looking much more better. So that's the difference between PA and AP view. So if you see PA view over here and AP view here, you can see the scapula and all those things. While X-rays can be taken in lateral views also, if you see the lateral view, in standing also, if I can take a lateral view, or in the decubitus position also, I can take an X-ray. So how it will look in the standing lateral view, it will look, while decubitus, you will find the patient who is sleeping on that side will be completely sort of compressed. It's nothing, there is a lesion over, but this is your scapula and all other bony structure which is going to present like that, while the above part will look very nice. So that's the difference, but that doesn't mean that you can reach some wrong diagnosis. But this you should be able to know that whether it is lateral position or decubitus position. Then how you see, do not assume that the heart is always on the left side. It can be dextrocardia or it can be situs inversus also. How it is being mentioned, you can see side markers are there, whether it is left, right, PA, AP. That's all been mentioned over here, whether it is right, then AP, PA, everything is been mentioned. What is the difference in dextrocardia and situs inversus? We'll come to that in the future slides. I got all those things. What about the rotation? Suppose the patient is being not comfortable to click. So patient rotates. If you see both the clavicle, if you see this is your sternum and clavicle, the distance between sternum and clavicle are very much normal. So you can see, but while if the patient is rotated, the clavicle will suddenly start looking rotated like that. So here you see the clavicle is rotated. So here the clavicle is here, here the clavicle is here. So that's the difference you will find. It's a thoracic scoliosis. You may diagnose it as a scoliosis, but it's a basically a rotated film. So one must see how much it is rotated, whether it is scapula is also rotated, clavicle is also rotated. So that doesn't mean that patient has got a scoliosis. Basically, we have to say that it's a rotated film. Now, underexposed, overexposed. If you see, this is underexposed, where you see very less of the heart, I mean, lung shadows, while this is overexposed, where it is too dark black, and you cannot just see everything, lungs very clearly or anything, even the markers. While here you will not be able to see the vertebral bodies at all. Here you can see the vertebral bodies very clearly because this is overexposed. Same thing, you can see the ribs also much more clearly. So whether it is underexposed or overexposed, also one should be able to make it out. Then you should see whether the film is being in the expiration or inspiration. If you see, this is expiration film where the diaphragm is being elevated up, while here inspiration diaphragm is being down. So if you see that also, inspiration normal positioning in the PHS, while expiration helps to visualize whether there is a pneumothorax, air trapping, etc. also can be seen if it is an expiration study. Now we can also see the details of the X-ray also before we really proceed to read the X-ray. Please always read the X-ray in a labeled fashion. Whether it is where is the lung, see as you can make out. This is a chest wall. These are the lung fields. This is a mediastinum over here. This is a diaphragm, and this is the heart. If you see, this is the way you will be able to see it. While if you go into much more detail, this is a slide which will show you exactly how it looks. If you can make out, this is the way you can find out whether this is your clavicle, this is a heart, this is mediastinum, this is a right atrium, this is a left ventricle, this is a carina, where you can see the diversion, this is a trachea, and then this is the lower zone, middle zone, upper zone. So this is the way you can make out. Normally we say up to second rib is the upper zone, up to fourth and fifth rib is a middle zone, and down is the lower zone. While on the right side it is much more higher as compared to the left side. This is the way it is also been explained in a different way, where you can see how it is being seen over here. So this is trachea, then this is the right apical area. These are the clavicles, this is the carina, how it is being seen very nicely. So this is your gastric bubble, this is the diaphragm, this is your heart. This is the way you have to analyze that. This is a cardiophrenic angle. So this is a costophrenic angle, cordophrenic angle. This is the way we are going to analyze it. So if you see the X-ray, normal X-ray, same X-ray I have drawn over here also, where you can see that this is a part of the superior vena cava, which can be seen in if it is analyzed properly, and all those things also. How it looks, see this heart is here, this heart is here. So only 1/3 is on the right atrium, while 2/3 over here is on the left ventricle. So this is the way we are going to analyze it. Now, ideally, how we are going to measure heart size is less than half of the transthoracic diameter. So if you see, if I can calculate draw a middle line and at the vertebral level, and then on the right apical area, whichever is the topmost A, and from down here, which is the last highest area, that is B, and diaphragm from here to one to other end, that is C. So now we draw the lines on the right and left heart of the border, and then we calculate it. And if you find cardiothoracic ratio A plus B, yeah, oblique divided by C, normally it should be less than 0.5. If it shows it is more than 0.5, that means patient has got a cardiomegaly. That is very nice to understand how to say whether a patient has got a cardiomegaly. Cardiomegaly can be related to the heart also. It can be related to pericardial effusion also, or anything. That is also important for us. Then, while the lungs are divided into 3 zones, upper zone, as I told you, upper zone ends up at the second rib, while middle zone second to third rib, lower zone is below the fourth rib. That is the one. So one must check also where exactly we like. If you find any problem over here, that means I can say that right upper lobe there is some problem. It may be lung abscess, it can be tuberculosis, or it can be anything. So that is the way we are going to say. If it is on the second and fourth rib, then I will say it is in the middle zone. If it is below that, I will say it is a lower zone. So that is the way we are going to analyze it. What about diaphragm? It's a smooth outline with an upper curve. Right diaphragm is always higher than the left because of the liver. So if you see, it is almost at least about less than 3, that, or I can say 2.5 to 3 centimeter higher than the left diaphragm. The highest point of the right diaphragm is in the middle of the lung, and that is the diaphragm. One must analyze. Now, bone and soft tissue also is very important, because sometimes they are not being calcified, sometimes they have been calcified. So that is also important to make out whether there is any fractures or not. If there is a fracture, you can see. If there is a radiolucency find, that means there is a metastasis on the bone. If the higher density there, that is oversclerosed bones. So we also see look for the breast shadows. I'll show you the slides later on also how that is important. I will show that. Now check below the diaphragm also, is there any gastric bubble? Bowel gas is there, organ size are there, abnormal calcification, free air, or the diaphragm on the left side is gone up also, so that I can make out the patient has got a gastric, what you call, stomach has gone up. So that is normally seen in the children also, which is diaphragmatic hernia that is been occurring. Then come to the foreign body. Foreign bodies can be anything, right from endotracheal tube, nasogastric tube, tracheostomy tube, central venous catheter, intercostal drains, pacemaker box, wires, artificial valves, and of course foreign body like coins, anything is screw or spring, anything is possible. So if you see this, you can make out, sorry, if you see over here, this is a central line that is going right from above. Can you see this red line? So this is a central line that is going on. So you can make out this is a central line going on. While if you see, this is the ICD that is put up in the second intercostal space. So possibly they were suspecting pneumothorax as well. So this is an ICD in the second intercostal. You can make out ICD. Why? There is the orifice over here. So there are multiple orifices also there, and that is the tip. So that is also way we can make out where is the central line. So if in the exam also they show you this X-ray, that doesn't mean you can say that there is a cardiomegaly only on one side. It will be more happy to say that I can see there is a central line that is being placed over here. Same thing, if this is shown, you can say, don't say this is a foreign body, it is on the second intercostal with a orifices over here. That means it is a intercostal drain, ICD. Okay. Now this is a pacemaker where you can see a pacemaker is placed here with multiple wires that are being going on onto the left ventricle, right ventricle, and all those things. So this is a left ventricle, right ventricle, and it's being carrying out like that. So this is a pacemaker that also can be shown in the X-ray. That what is this? Can you diagnose? Then how to distinguish whether it is a mitral or a aortic valve? This is a very simple way to analyze. If you see on the lateral film, draw a line from the apex of the heart, that is from the here, from the apex of the heart to the hilum. And then if you see, if it is above, that is aortic, if it is below, that is mitral. Or otherwise, you can make out here also. If you see on the PA view, draw a line from the angle of the, lowest angle, cardiophrenic angle, draw a line to the pulmonary conus. And if you find any valve down, that is mitral, while any valve that is up, that is aortic. So this is the way we are going to read it, whether it is aortic valve, valve, because in the exam they may ask you also whether, yes, it is some foreign body, something. Sir, it is mitral valve, or which I'll say if it is mitral valve, why you say mitral valve? You should be able to analyze and you should be able to explain that why this is mitral valve, why not this is aortic valve. Okay. And then come to the mitral stenosis, how it will look. If you see, this is the marker I have placed also, that one, that means it's a right border is made double. Normally it is up to here, but it is extended. So there is a right atrial has become very big. Then if you see number 2, this is the one left border is being straightened. So it is being straightened like that. And third is a left main bronchus, left atrial enlargement is there, so you will not be able to see here anything. Causes can be anything, but I'm just telling you, you can say that this is a mitral stenosis. It may not be calcified, so you will not be able to see the mitral valves at all, or replaced also. But you can say that it looks like it's a mitral stenosis. While if you see, this is also there where you will find that large heart is there with a pulmonary hypertension is present. If you see over here, one, there is a prominent right atrium over here, and there are dilated vessels over here that you can see. These are the pulmonary vessels. So this is basically a shunt that is been happening. Okay. So this is very important way to diagnose if they show this X-ray. Now come to the next one, that is whether it is a, what is this called? Can anybody tell me? Oh, it's not going. Yeah. This is the one which shows a globular heart with a hilum that is being covered very big. Lung fields are looking very much narrow though, but it can be a basically pericardial effusion, that it can be transudate, can be exudate, it can be blood. It can be trauma, so blood, it can be exudate, it can be transudate. Transudate can occur in the any cardiac problems, and exudate can be because of the infection. So this is a typical pericardial effusion where you will see the heart is looking too big as compared to the earlier size, normal size. While here, if you see, there is a widened of a mediastinum, where which can be many causes. If you see the mediastinum is widened a lot, so this widened mediastinum is there. This can be because of the thyroid enlargement, which is very big. It can be mediastinal nodes are also there. It can be because of aortic dilatation. It can be thymic tumor, or it can be a hyperdilatation or of the esophagus. So any one of these are the possibilities. So whenever exam this is being asked rarely, but still you must come out with diagnosis at least, if not all those things, at least two, three you should be able to tell. Then this is what I was asking, that whether it is a hydropneumothorax or pleural effusion. So what is the difference between hydropneumothorax and pleural effusion? If you see hydropneumothorax, there is a what you call liquid over here. Pleural effusion type effusion is there, and air is there. So whenever there is air above, it will keep the valve, the pleural effusion flat. So the thing is, this is flat because of the air there, which is flat. While if you see the pleural effusion, so this is a right-sided hydropneumothorax. While if you see the pleural effusion, can you see this pleural effusion over here going up? So why it is going up? Because there is no air, so there is no pressure over there, and plus there is always a there is always a suction that is been happening with the peritoneum, rather the uh, pleural effusion gets basically gets sucked up also. So you will find this going up in a U shape. So this is the way it is, not a hydropneumothorax. Hydropneumothorax, you get a darker shadow over here, no lung shadow, where here is a pleural effusion. There may be 1,000 causes of pleural effusion. See, these are very important. One can be transudative, so if a liver cirrhosis also can cause it, a renal problem also can cause myxedema. Exudative can be because of malignancy, can be tuberculosis, can be pulmonary embolism, can be infection, can be trauma, it can be SLE, it can be chylothorax, it can be ruptured esophagus, and types of fluid. If it is serous, it is hydrothorax. If it is the blood, it's hemothorax. Chyle, it's a chylothorax or empyema. Pus, it's a pyothorax. And if you urine, it can be again urinothorax. Anything is possible. So one must remember these words. Now, next is, if you see this side is completely looking opaque on the left side. Why left side is completely opaque? There may be causes it's completely left, this hemithorax is completely opaque. Reason is it can be a lung collapse also, maybe mediastinal shift also. It can be a big empyema, hemothorax, chylothorax. It can be a pneumonectomy has been done. That's the reason. There is no air, nothing is there. So you will find it has been, there is a consolidation or something like taken place over there. There may be tumors which are being pressing onto the pleura or mesothelioma, and it may be a massive pneumothorax, pneumonia, or any neoplasm which is obstructing the left-sided complete the bronchus. So that's the reason there is no air exchange at all taking place on your left side. So that's the reason it is looking completely. And if you see over here, there is a shift of the mediastinum also on this side. Same thing, trachea is also shifted onto pulled onto this side. While right lung is okay, and in fact, this is looking more darker because it is been overworking as compared to left side. Your patient has to leave, so that's why it happens. Now, if you see this type of things, this is what we ask, what is your diagnosis for this? So this is a bronchiectasis. If you can see, there are multiple bronchial things which you can see. It's not that it's a consolidation. You can see multiple bronchus-like structures which are having infection. So that is what we call it as a bronchiectasis. Okay. While if you see this second one, these are the multiple million nodules are there. If you can see these million nodules are there, small, small, small. It can be miliary tuberculosis. It can be dust inhalation if you're working in a factory where there are dust has been there, or a pneumoconiosis also. It can be multiple metastasis also that has been happening because of thyroid or melanoma, or it can be silicosis. So that is also important. Now, if you see this, this is tension pneumothorax. Why tension pneumothorax? Because it may be because something like there is a needle or stabbing is occurred, so there is a pneumothorax over here. That is the reason it is why it is tension, because if you see, there is a complete diversion of the mediastinum, trachea, and heart also onto the opposite side, onto the right side. That's the reason you can make out this is called as a tension pneumothorax. This is X-ray showing a tension pneumothorax. Okay. While this is a X-ray which will be emphysematous, which you can see it's a very big, long type of chest. Chest has become very big and long. So that is the reason you can see intercostal things, spaces are also becoming very big. So these are the basically emphysematous chest. That's the reason there is no other infection, but the chest is looking very big in dimension. The reason being emphysematous chest. Next comes this, which will be seen a pneumonic patch on the right lower lobe. So it's a pneumonic patch that has been happening. While left side is okay, this is your diaphragm, this is your epigastric fluid and epigastric area. So this is your lung, this is your lung, while this is your patch. So this is a pneumonic patch that's happening onto the right lower lobe. Now this is pulmonary edema that is happening. There may be multiple causes of pulmonary edema. You can see it can be a left ventricular failure, it can be a near drowning patient, it can be an aspiration, it can be ARDS, or it can be high altitude, which can also lead to a pulmonary edema because you are not used to high altitude. Suddenly, the people who stay high altitude, they are used to it. So this is very important for us to remember. So you should be able to tell the multiple causes also. Now, this is what is very important for you. If you can see this roundish one, this is a lung abscess type. If you can see, this is also in the right upper one, while here it was middle lobe, while here it is on the left middle lobe. So these are all the lung abscesses. So it can be pyogenic, it can be tubercular, it can be anything. Now this is very important one, very complicated one. If you see this patient is pulmonary edema with a congestive heart failure. So that's the reason you see a typical bat wing type of appearance over here. If you can make out over here, everything is looking like a pulmonary edema. This is your heart shadow, but see the lung, which is a pulmonary edema. So this is also possible. Now, this is the one which we can say a pulmonary tuberculosis in a patient where it has got a multiple type of tuberculosis nodes over here, which you can make out over here. This is a pulmonary tuberculosis. Of course, you can do the test also, and then you can find out whether it's a tuberculosis or not. Now, this is what we call it as a what it will think it can be. It's basically multiple metastases that can occur into the all the malignancy type, where you'll find one met here, one met here, one met here, one over here, one couple of over here. Here also you can see. So this is a multiple metastasis. Cause can be malignancy, can be anywhere. Now this is very important. Slides foreign body. This is being kept shown to the exam and tell me what is this foreign body. The thing is, many students say something very differently, but remember one thing: if it is going below carina level, then it is basically, it is definitely into the a coin which is in the esophagus. Because carina is normally up to 4 level, T4, T5 level at the most. So this is in the esophagus. Of course, in the exam, you can always say, I'll prefer to go for a lateral plate also. If I got a lateral X-ray, that is good. But this is placed quite below, so it is definitely in the esophagus. But if you see, this is higher up. So in this condition, definitely you will have to tell that this is, I will definitely prefer to go with a lateral X-ray plate also, so as to make out whether it is placed, this coin is placed behind or it is placed in the trachea. Of course, here also you can make out the lungs are looking, both are looking quite good. The ventilation looks quite good. So it may not be definitely into the trachea as of now. Because if you see the trachea down over here, if this is your trachea, you can make out the carina down. While here you can see, I will definitely go and tell that this is not at all into the tracheobronchial tree, because if you see, this is a tracheobronchial tree where you can see that lungs are okay. So this looks like it is very much into the larynx or at the most into the upper esophagus. So this also you can make out. Okay. While see this is the one which are the foreign body. Here AP view and lateral view has been taken. So if you see this AP view lateral view demonstrates there is a round opaque foreign body in the mid esophagus at the level above carina. So if you see carina over here, and if you see carina and all things are going on like that. So it is behind the carina. So naturally it is in the esophagus. While here, if you see, this is your uh, trachea, esophagus is below, but here you can see there is definitely right lower lobe bronchus is there, principal bronchus. So this looks like it is a foreign body into the right main bronchus. You can see this is a right main bronchus because esophagus is again centrally placed, so it cannot go into diversion. So here you can make out it's definitely into the right lower lobe or main bronchus. While here, if you see, it is above the level of carina, so naturally it is in the middle of the esophagus, mid esophagus. Because if you see, carina is ending up to T4 level here. So carina is ending here and it is below. So it is at the middle esophagus, middle third esophagus, it can be seen. While here, if you see, this is a one which is again in the esophagus because if you see the esophagus, trachea, carina, and both lungs are looking quite okay. While this is quite below the T4 level. So naturally, it looks very much like in the esophagus. It is not reached the stomach as of now. Same thing here. This is also in the lower esophagus. Because if you see carina, can you see the air shadows over here? So this is your carina and this is over here. So this is again, of course, lateral view will be better. But in case you don't get lateral view still, you can make out this is in the esophagus. While here, this looks definitely into the right main bronchus. It may be a peanut or whatever it is. This is a peanut which can be in the right main bronchus. Let me be honest. This is an X-ray chest of my own son. My son, when he was 1 year and 2 months old, he was eating that peanut in my neighbor's home, and thereafter he filled his mouth, and then he suddenly started laughing and he aspirated. In fact, after 4 days, because the neighbors never told us, fourth day when we tried to remove under the bronchoscopy, the peanut became into the 100 pieces where we sucked out, but still it took a long time for us to get. This is a foreign body in the right main bronchus. Okay. Now this is very important slide for you to make out what is your diagnosis for you. If you see, this is your endotracheal tube. Can you see this? This is endotracheal tube, which is going mainly into the right bronchus. So that is the reason left bronchus is not getting ventilated. And it has gone into the right lower bronchus. So upper bronchus is also not getting ventilated. So this is a endobronchial intubation mainly into the right lower lobe and middle lobe. That's the reason right upper lobe is not getting ventilated and left lobe complete is not getting ventilated. So this is your tube. Can you see these markers are over here? I put the markers over here to make out. This is a endotracheal tube which is going down. Now, this is also very important for us to make out. This is what is being asked. I think this has not come out properly. Basically, if you see, this is being asked in the examination in Tata Memorial, where they show this X-ray, and the many students read. So this is a normal X-ray, chest, heart, lung, everything is looking normal. But please remember, everything looks normal. But if you see this side, the breast is there, while this side, the breast is not there. For Tata Memorial Hospital, Cancer Hospital, one must have to say that possibly this lady has undergone a right mastectomy. Otherwise, the heart, lung, everything is normal. Now, this is where you see a big mediastinum over here. If you see, there is an anterior mediastinum mass. It can be a retrosternal goiter, or it can be a thymic tumor also. These are the possibilities. Now, this is what we call it as a people will confuse. First thing they say, sir, this is a X-ray, galat rakha hai. It's not wrongly kept, it is correctly kept. But then again, then they say, okay, sir, because if you see, it's written very clearly over here, left. So this is the left side, this is the right side. Now your heart is on your right side. Again, the people get confused, student gets confused, whether I should say it as dextrocardia or whether I should say as a what? Situs inversus. If you see, if I can see this epigastric air, stomach air on this side, then it is dextrocardia. But if you see the epigastrium and stomach air that is on your left side, that means it is situs inversus, where your heart is also this side and gastric bubble is also on this side. So this is situs inversus. While if you see the gastric bubble over here in the left diaphragm, then you can say that this is a dextrocardia. Okay. This is a big cardiomegaly. If you can make out, it can be many other reasons are there. It can be ischemic heart disease. It can be valvular heart disease. It can be dilatory cardiomyopathy, which can be viral, alcoholic, metabolic, or it can be a pericardial effusion. Same thing over here. This is a pericardial effusion. There are many etiologies over there. It can be idiopathic. It can be inflammatory. That can happen post-MI. It can be infection because it can be viral, bacterial, or tuberculosis. It can be surgical trauma. It can be pulmonary hypertension. It can be post-radiotherapy or malignancy. It can be pericardial mesothelioma, or it can be hypothyroidism, which can lead also to this. Okay. Now, this is what we see over here. Entire thing is going over here. This is a diaphragmatic hernia, congenital diaphragmatic hernia. That's the reason you see on the left side, the entire bowel is going up. So your heart, everything is being shifted onto the right. This is a congenital diaphragmatic hernia. Now this one is fractured rib. Of course, if you see over here, I don't know whether the pointers are there. See, there is a definitely radiolucency over here and here. So this is what we call it as a fractured rib. Widened mediastinum is also there, which I already showed you. It can be thyroid, it can be mediastinal nodes, or it can be thymic tumor also. Now, this is very important. If you see here, this is your routine gastric bubble that is in the epigastrium, but here you see there is a gastric bubble also on to the left side. So it can be gas under right diaphragm. It can be because of intestinal perforation or trauma to your abdomen. That's the reason you see there is a gas under the right diaphragm as well. Thank you very much. Yes.
Thank you, sir, for a very informative class.
Well,
Sir, if you may.
one more thing I must share with you. Very interesting case that has happened in Tata Memorial Hospital once. You know, it so happened there was some 15, 16-year-old boy who was playing football. So suddenly, let's say Sukhminder Bajwa threw a football and hit me on my chest. So once he hit me on chest, I became breathless. I became breathless. So I was thinking, what's happening? I just rested. In front, there was a Nanavati hospital, which is very right in front. They took over there. They said there may be pneumothorax, maybe a rib fracture. They put a needle on your right upper second intercostal rib. No air came. Then they put in the right lower zone, that is 6 and 7. Can you believe what has come out? Arshdeep? You may be thinking there may be blood, but no, the chyle came. There a chyle came, which was initially they sucked out 100, but it came out more, so they put an ICD. And then he was admitted over there for 2-3 days. Third day they took an X-ray test. Every day he was losing about 1,000 plus ml of chylothorax. chyle was coming out. Third day, they found, I'm drawing over here, middle, third, fourth, fifth rib, middle third, gayab. There were no middle third ribs seen. We are wondering what's happening that. So they thought they took an X-ray again, but nothing came out. Then they said it's a chylothorax. We have to do the thoracic duct ligation. But we are not trained, so send him to Tata Memorial. He was brought in Tata Memorial, but when he was brought in Tata Memorial, we saw it's not only 3 ribs over here, middle third, cervical, C7 lamina was also disappeared. We are wondering what is this. So I could not extend, but thankfully I intubated this patient very nicely. Surgery was done, they did the thoracic duct ligation, and after thoracic duct ligation, everything was okay. But third day post-operative, the left-sided chylothorax started. Again, left-sided ribs started disappearing. So he went into the completely thoracic wall collapse. So they could not, I mean, none of us could diagnose. So their relatives were there in America, so they sent the X-rays and all those things to America. Can you believe what can be the diagnosis? Something to add your knowledge. This is called as a Gorham syndrome.
Okay,
Or
sir.
it is also called as a vanishing bone disease. Yes, now you can talk better.
So indeed a very enlightening class. Sir, if you may allow, we can take a few questions in the chat box.
Sure.
Yes, sir. So one question we have is, if required in an emergency, for a need of chest X-ray in pregnancy, how to proceed?
You want a pregnancy? Pregnancy, is it a full term or not? Because if you are going to take an X-ray chest within 3 months, it can affect the baby, the child. But if it's more than 3 months, of course, if you are suspecting something in the chest, I don't mind, I can go for an X-ray. For example, if that lady had a fall, I'm suspecting rib fracture or something, I don't mind after 4 or 5 months. But not more X-ray, one X-ray only. There's nothing wrong. But within 3 months, you should not take because it can affect the child.
Okay, sir. So another question is, a difference between situs inversus and dextrocardia. I think you've taken it up.
Already told you that in situs inversus, you will find the epigastric area just below your epigastric area on the diaphragm on your right side. You will find there is a gas under the diaphragm on the right side also. And your heart is also on the right side. That means it's situs inversus. But if your heart is on the right side, but your stomach gas is there on your left side, then it is called as dextrocardia.
Yes, sir. So that's all the questions we have in the chat box.
Thank you. I think you can come to the big screen. Why screen is not a big?
So you will have to stop sharing your screen.
I already stopped, beta.
Don't worry, don't worry. It will be done.
I don't know how to do that stuff.
Don't worry, sir. I'm doing it.
Yes, it is done.
Right. So no questions today. That means this is very
She asked
beautiful
me
class.
2 questions. She
No,
asked me,
sir, 2 questions for Dr. Gedu sir, only 2 questions. 9 Safi hai. No.
The thing is, thank God Sukhminder is not asking.
No, I am not saying anything.
But how was the class? Was okay?
Yeah, it was good class. Just missed 5 minutes of it. Otherwise, I was seeing almost every diagnosis and whatever the presentation you were doing, it was good for all the PG students. There was a lot of knowledge to be gained from these type of classes. Dr. Lalit Raigar want to say something. Just wait, sir. Just
Yes.
wait. No,
Lalit
just
Raigar. Oh,
no,
wow.
Lalit Raigar, sir. He is the
Yeah, I know Lalit.
another teacher of teacher is there.
Yes, Lalit ji, bolo. Where is Lalit? I can't see him. Yeah, there it is.
Good evening, sir.
Hi, good evening.
Sir, if required, we can do X-ray chest with lead shield,
With
with shield
for what?
in pregnant lady, as you had mentioned, if required.
If required, no, no, it will not protect the child.
Okay.
Sir,
The child is oversensitive. Within 3 months, child is very oversensitive. Even if you put a shield, it will not protect you. So unless it's 3+ months, then I don't mind.
No, even the shield, sir, I think the penetration of the rays in the body actually.
Yes.
You can't
Okay.
prevent the rays from going even with a shield you put anywhere in the around the abdomen or somewhere.
All X-ray technician, radiologists, they put the shield and they take. But if you see, they ultimately have the radiometer also, which ultimately they show after some time that there is a lot of radiation they are getting also. So that is not
Yes,
going
sir.
to protect you completely.
Thank you,
Thank you, Lalitji.
sir.
Dr. Parna want to ask Asha Sharma.
Doctor?
Unmute. Whosoever want to ask, unmute yourself.
Yes.
Yeah.
Gedu sir, it was an excellent lecture. It was too good. In fact, I told my son also to attend. He's in 3rd MBBS. He's not anesthesia student, but I told him to attend. It was an excellent lecture, sir.
Who's this
Excellent.
Parna Takkar? I don't know. The
Thank
reason
you,
is
sir.
she was
Thank you.
supposed to give me party, but she has not given, so I don't know.
Very nice. Very nice.
Thank you,
Thank you.
Dr.
Thank you, Parna.
Thank you. Thank
Dr.
you. And in
Asha
fact, I put it up in our students group also that it's a very, very important lecture. Please attend. So I don't know how many are attending, but very nice, sir. Thank
Madam,
you.
you take attendance of them, roll call करो, यहीं पे attendance हो जाएगी उनकी.
Yes, sir. Yeah. Bye. Thank you.
Dr. Asha Sharma. Kindly unmute yourself.
Asha Sharma is not unmuted.
No, sir, they can unmute themselves. No problem about that.
I know, but she's not unmuted still.
Anybody else?
So there's another question in the chat box. How to differentiate pleural effusion and empyema?
Pleural effusion and empyema cannot be differentiated. Only thing, if it is radiologically, it cannot be differentiated. Of course, if I aspirate, I will definitely find it a difference. But the thing is, only difference is only hydropneumothorax and pleural effusion can be differentiated. Because in pleural effusion, you get this U type, while in hydropneumothorax, you get a half straight lump. And plus, there is air above.
The best is only with a diagnostic aspiration. Otherwise, it's very difficult to radiologically differentiate. Any other question? Okay, in the meanwhile, somebody remembers one question, we can always felicitate our faculty. Screen is visible?
Yep.
Yeah. We are really thankful to Dr. Gedu sir for holding the fort today for this class for the X-rays. And sir, we are very indebted to you for being a part of this class as a faculty, the lead faculty.
Thank you. Thank you.
Much, sir. Thank you,
Thank
sir.
you, Shukminderji. Thank you so much.
Then Ramesh Reddy sir is also there as a co-moderator. He had some busy schedule. In spite of that, he has joined the class. So thank you, Dr. Ramesh Reddy sir. And the student Chinmay as well as Dheeraj. Thank you very much for being a PG student and taking whatever you call guts to prepare in 1 or 2 days for everything.
Yes. Thank you very much for the opportunity, sir. Thank you very much.
Then Arshdeep, I'm really thankful to you. She is my senior resident at Gyan Sagar. And Arshdeep as well as Vignesh, they both are my alumni from 32 Medical College. So pass out from there. So thanks to both of them for holding the class today.
Thank you for the opportunity, sir.
And Ridhima also,
Thank
she
you
was
very much.
instrumental in teaching the technical parts to our class coordinators. Dr. Agnihotri wants to ask something.
Yes,
Sir,
sir.
sir, please.
Good evening, sir. Thank you, Dr. Gaidu, for nice illustration of the X-rays.
Thank you, sir.
I
Your blessings
request
are
that
important.
I request again Dr. Bajwa that Dr. Gaidu should take the separate class X-ray in ICCU for various interpretations. Because every time the anesthetist goes to the ICCU and they get muffled regarding the differential diagnosis and interpretation of the X-ray in ICCU. So it is my suggestion, if you can spare your valuable time, please give it. Thank you.
Now he has to, sir. Our Agnihotri sir is our past president, past
Yeah, I
secretary of
know.
ISA,
That's the
and
reason I said
when
he's a
whatever he
respected
says,
person.
must have suggest for the class because he is always present in every class. He has missed only one class till date, but he's always there in every class. So whatever suggestions sir gives, because many of the things modified here in this class are because the suggestions given by Agnihotri sir. So I think Gedu sir has to comply to these type of suggestions and advices. Please, sir.
Yes, I'm 100%. Don't worry. When
Within,
Agnihotri sir,
sir, within
respected
2-3
sir.
months, within 2-3 months, we will have a class on the X-rays in the ICU as well as in emergency also.
Yes.
Yes, please.
Both will be included. In
Thank you
that.
very much.
Thank you, sir.
God
Thank
bless.
you very much, sir. Arshdeep, there is a question. Vignesh, you can see from, you can ask
Yes,
Gedu,
sir.
sir.
There is another question, sir. How to differentiate between aspergilloma and lung abscess in the X-ray, sir?
See, lung abscess is, of course, it's going to be very much in one of the area that is being the upper zone, middle zone, whatever zone, where aspergillosis is going to be there in the entire trap part. Lung abscess is not there in the entire lung. It is located in one of the areas. So lung abscess can be in the positionally there, but aspergillosis is not a positional one.
Anything else is there?
Yes, sir. There is one more question on we have is how is water lily appearance in Echinococcus granulosus? How could
Sorry?
it be visualized? Water lily appearance in a patient who with infestation of Echinococcus granulosus. How can we visualize in the X-ray there?
In X-ray, if it is there now, it will be visualized as though it is absolutely flat one. Because in such a condition, there will be a small amount of air also is there. So it can be showing as a flat also.
I think it was a good class.
I think I also told you the experience, my experience about Gorham syndrome. I believe, Sukhminder, you heard that. No, you didn't hear. Sukhminder, you didn't hear that.
I missed it for 5 minutes, told you, na?
So I had one very nice experience in Tata Memorial. I think I already shared with
that I will sit with you and listen. I will sit with you and listen rather than on the class now. I will sit with you and listen.
Yes, yes.
But D.Y. Patel, I will be coming to that. Then I will listen to that. And in the meantime, we will see the progress of the next class of ICCU also.
Yes.
ICU and ICCU, the X-rays in ICU and ICCU.
Okay.
Anything left? Nothing. It was very short and sweet class today. So, Gedu sir, thank you very much. And अभी भी क्वेश्चन आ रहे हैं.
Yes, sir. We have a question. Can you please elaborate on the features in pulmonary edema apart from increased bronchovascular markings?
Can we elaborate?
On the features of X-ray features of pulmonary edema apart from increased bronchovascular markings and battering.
No, apart from increased bronchovascular, baki rest of the things are all clinical signs and symptoms which patient will get. That you are getting breathless, you may be having a lot of problem with the respiration, you may start even aspirations and all those things can be reason. So if that is one of the reason also possibility.
And even I think, sir, even the bronchovascular markings, how much prominent they are, they also depend upon the duration of
that
the
I already told,
the severity. And if a person like me also sees for first time, I may not be able to with the bronchovascular markings, very much prominent. So it's a difficult level. I think the clinical part is more important. Even the patient is on ventilator, then I think the dynamics of the ventilator, they will help you in deciding the clinical diagnosis.
Who's this Nishant Sahai?
He
Somebody
is
commented.
praising. Nishant is always praising. Nishant is always the part of this class also. He's praising about it.
Good evening, sir. Good
Gorham
evening.
syndrome.
Gorham syndrome, really interesting case, sir. Very
अरे
interesting.
निशांत तुम्हारे पीछे सूरज कहाँ से आया इतना बड़ा?
Sir,
Hello, hello around you.
yes, sir. Yes, sir. 1 minute.
This actually we have experience in Tata Memorial. I'm telling you, it was a very bad experience for us. I mean, this is the first time we have heard. In fact, the first case that has been reported was in the African country where, you know, a poor man was hit on the middle third of your, what you call the humerus. So what happened? This bone, a middle third bone disappeared. So you are a poor person. So you know what he started? He started earning with that because he started rotating from here.
Oh, wow.
And rotating reverse. Please give me money. Give me money. So that was the first case, and this is the second case we heard.
Yes, sir.
Gorham syndrome, already also called vanishing bone disease.
There
You
is
can Google
proliferation.
it. You can Google and you can find out.
I saw it, sir. There is proliferation of the thin-walled vessels, which causes a resorption of the bone. Very interesting.
It's because of the basically it happens because of the what you call the chylothorax. Chylothorax is the one which is to be blamed because your chyle is very rich in protein and fat. So that all leads to your exhaustion of the bone cement and bone what you call calcium and all those things.
I will read again, sir.
Yeah, sure.
Vignesh and Arshdeep, if nothing else, shall we close the class?
Yes.
I think.
Yes, sir.
Yeah. I think. Thank you everyone once again, especially Gedu sir and his team. We will meet in the next class. Next class is based on the posterior fossa surgery. So next Monday, 6:30 p.m. we will be again together. Till then, it's a goodbye and long live ISA.